This is Dr. Donald Allegra. He's a board-certified infectious disease physician at ID Care Associates. He's an associate professor at Tulane School of Public Health and Tropical Medicine. He's also the chairman of our pharmacy committee, and he's an infectious disease consultant on Fox News and NBC. And he's also my favorite title of all. He's an alum of MEDIPATH International, as he came to lecture at our first emergency medicine symposium last year in Sofia, Bulgaria. So welcome, Don Allegra, back.
Okay, thank you, Michelle. First of all, welcome to everybody who's here. I know it's a Sunday and it's everybody's busy and wants to do other things, but I'm glad you all tuned in. Michelle introduced me. As you probably know, Atlantic Health System is a 5-hospital system. We are in the New York metropolitan area, and we were hit very hard in April and May by the COVID outbreak. And now we are concerned about possible second wave coming to our area. So that's where we are right now. I think that everybody in the audience, no matter where you live in the world, has been affected by this pandemic. It's ravaged the economies of the entire world. It's killed 1 million people already, and we're still not done with it yet. We're still in the midst of this. And several parts of the world, including Europe, are now seeing second waves, and we're starting to see an uptick of cases in the United States also. I'm going to try to talk more about an international perspective rather than just a specific USA perspective, because there's so much we can learn from what has been done and what has been tried in other parts of the world. And I'm going to try to go through some of those lessons. Next slide. So my goals are going to be to review the epidemiology of the global pandemic in the last few months, and the scientific data of what is known and what is not known. And at the end, I'm going to be trying to predict what's going to happen with this pandemic. Of course, no one really knows for sure, but I'll take a shot at giving my opinion. Next. I think I have to put a disclaimer in here. You know, we're used to in medical science doing these randomized control studies, and they're a hallmark of great medical science. But in the rush to publish, data with COVID has often not been confirmed or properly vetted by peer review. And even articles in very prestigious journals such as The Lancet in the UK or the New England Journal of Medicine in America have actually been withdrawn even after publication. I'm going to try to summarize some of the known science, but much of what I say will obviously be conjecture or opinion and not proven fact. Next. This is our enemy. This is a picture, an electron microscope of COVID-19. As you can see, the name coronavirus comes from the spike proteins that you can see are in red on the top of the virus. And these spike proteins actually find the receptors in human cells and attach, and that's how they enter cells. Next. Now, coronaviruses have been around for a long time. This is not a new category of viruses. In the winter, it causes about 5 to 10% of all respiratory infections. What we call the common cold is very often a coronavirus. And when there are real outbreaks, sometimes you can get as high as 30% of respiratory infections can be coronaviruses. It's a medium-sized enveloped RNA virus. It has 4 genuses, beta, gamma, and delta. COVID-19 is a beta coronavirus caused by a virus designated, has a name called SARS, which is severe acute respiratory syndrome. And because we've already had one COVID or one SARS virus that's named COVID-1, this is called COVID-2. But SARS that we had in 2003 and MERS, which is Middle Eastern Respiratory Syndrome, are also coronaviruses, and we started with that in 2012. Now, SARS actually had a mortality of about 10%, or 8,000 cases, and MERS has been in 300 or 400 category in terms of number of cases, primarily in the Saudi Arabian Peninsula, and spread through what is thought to be a camel intermediary, but that has had a mortality of about 35%. Bats appear to be the primary source of COVID-19, And COVID may have been introduced, although we're not absolutely certain, through a secondary mammalian host in a live animal market in Wuhan, China, which was the first epicenter of this outbreak. Next. So the timeline, it first started in China, as all of you know. We had our first current case in our western state of Washington on January 21st. The first case in Europe was in France on January 24th. And then the first death in Europe was February 15th. And the first case actually in Bulgaria, where I know a lot of you are from right now, was on March 8th. So it's really, when you think about it, this has not been around for a long time. In the last 6 months, we've gone from 1 or 2 cases up to 35 million cases in the world. So this has been a very dramatic increase in cases over the last 6 months. Next. It's really the perfect storm. It's a novel virus, so we have no protection in the population because we've never seen this before. It has very high transmissibility. We've gone from 1 case to 35 million in a matter of 6 or 7 months. And almost every country in the world has been affected. And it appears to have a higher mortality than our seasonal influenza, but I'll be going through that more. Next. My first question, and I want you to answer yes or no. Do you think COVID's a bigger problem than Spanish flu in 1918? I'll give you a few seconds to respond. Okay. So about 1/3 of you think it's a bigger problem than Spanish flu in 1918, and 2/3 say no. Okay, let's go to the next slide and see where it fits. The Spanish flu in 1918 claimed 675,000 deaths in the US when our population was 1/3 of what it is now. But actually, we have 1 million deaths so far of COVID in the world. We don't know how many it's going to go to. But it was 50 to 100 million deaths worldwide in 1918. And so far, it's less deadly than the Spanish flu was. But just think about the ordinary flu season. Many of us don't really feel that keen about getting our flu vaccine each year. But in 2019, we had about 60,000 deaths in the United States alone and 30 million infected. And if you really go back to the Black Plague or the bubonic plague in Europe between 1346 and 1353, that was only 8 years. There were 50 million deaths in Europe. And the population of Europe at the time was estimated to be only 83 million. So that's a death rate of 60%. Talk about a really high attack rate. That was really an incredible time. It took years for the population of Europe to come back to what it was before the pandemic. So the total cases we have in the world now is about 35 million. In June, just 3 months ago, we only had 10 million. And as you can see, the deaths have gone up pretty dramatically. In April and June, it was just 400,000. Now it's over 1 million. In the top 5 countries in the world, the USA is, we only have 4% of the world's population. We have 20% of the cases. We have 7.3 million cases, but we're averaging about 43,000 cases a day. As just a sidelight, Europe is now up to about 100,000 cases a day. India was way down there in the list, but now it's up to 6.5 million cases. And at its current rate of spread, it's going to probably be move ahead of the US in the next month. Brazil is another hotspot, about 5 million. Russia's 1.2 million. And then Colombia in the southern hemisphere of the is 800,000. And then everybody else less than 1 million. But that's where it sits right now. And then the epidemiology in Europe, where many of you are from. Spain actually has the most, about 800,000, then France. Italy center initially in Europe, and where the northern part of Italy and Lombard region had, was really being overwhelmed, has about 300,000 cases, then Germany, the Netherlands after that. Now Bulgaria, this is from about a week ago, had 21,100 cases. You have a population of 7 million in Bulgaria. We've had about 800 deaths, and you have about 200 or 300 cases a day. Now, as a comparison, New Jersey, where most of the faculty lives here in the United States, we have a population of about 9 million, so it's a little bit bigger than Bulgaria. We had 200 to 400 cases ago, where you are now, but then recently we went up to 700, then up to 1,000 cases in the last week. So now we're sitting around 900 cases a day. So we are starting to see a little bit of an upsurge, not a true pandemic yet, but an upsurge. And the reproduction rate in Bulgaria is 1.13, and I'll go through what that means, the reproduction rate of the virus, in a minute. In the United States, what's really happened is we've had a rolling epidemic. Initially, this affected primarily the West Coast, Washington State particularly. Then it jumped over, affected the New York metropolitan area, which is where I live. But now 35 of our 50 states are experiencing increasing numbers, and we're having large outbreaks. It went from the east, and then it went to the south and southwest of the United States. And now most recently, it spread to the rural middle of the United States. And our highest cases now are in the middle of the country, which are the most sparsely populated. And also the epidemiology has changed. Initially, 40 to 50% of our deaths were occurring, and most of our cases were occurring in nursing home patients. And now 50% of cases are under 35 years old. Many of our states never went into real good lockdown or required masks in public. So there was no dampening effect on the number of cases. And then when they start opening the economy and having, indoor dining and sport events, et cetera, we're starting to see increased number of cases. Now we're seeing about 43,000 cases a day, but we were at a high of about 70,000 cases a month or two ago. And as you probably know, the EU has restricted visitation by US citizens since this summer, since we had such active pandemic going on in the United States. Next. So what's happening now is we had a very high hospitalization rate initially, both in Italy, particularly, and then in New York area. And now we're not seeing the high hospitalization rate we had before, nor are we seeing a high number of deaths, but we're seeing a lot of cases. Now, why do you think we're not seeing the high hospitalization rate? Is it because A, cases are occurring in a younger population who tend not to be as sick? 2, we are protecting our high-risk populations such as the elderly, because now that we know that those are the ones most at risk. C, where treatment is better, so less people are dying. D, deaths are a lagging indicator, and they're going to start to rise as young people infect their parents and grandparents. Or E, all of the above. It looks like most of you think that all of the above. Okay, let's go on and examine this issue. Why are cases up but the death rate down? It's probably all of the above. Deaths are certainly a lagging indicator, and they are starting to rise. And I think the better indicator of future deaths is really looking at your ICU census in the country or the state where you live. Because if your ICU census is high, that usually predicts higher mortality. And most of the time, what we've discovered in America is that the younger population gets sick. 9 to 14 days later, their parents get sick, and then their grandparents get sick 2 to 3 weeks later. So it's a little bit of a lagging indicator. And since most of the deaths are occurring in the older population, you're going to see increasing deaths if you're seeing increasing cases in younger people. And now better treatment, I'm not so sure about that. I'll go through that in a minute, but sure, we have some treatment now. We do understand a little bit more about the disease, but we really don't have anything that's really a cure for this disease yet. We are doing better isolation of elderly in nursing homes. It was devastating what happened to our nursing homes. In New Jersey, 40% of our deaths were in nursing home populations. In some states, it was as high as 80% initially. And we are isolating better. We're checking staff on a regular basis, and we're preventing visitation of our elderly from family members. But I really think it's probably a combination of all of these that the death rate is lower now. Next. I just wanted to just show you the epidemic curve in my state of New Jersey. As you can see, the big peak occurred in April. Then we went all the way down this summer. But as you can see, that line at the end of the graph there is slowly increasing now. We went, as I said, from 200 to 400 cases, and now we're 750 to 1,000 cases a day. Next. One thing I really want to mention, this was at one of our hospitals. You know, we were really desperate. We were running out of ventilators, and our ICUs were totally filled. We banned all non-essential surgery. But look what happened. The red that you can see in the slide is the flu epidemic we had last winter. And as you can see, it peaked in about April and then fell down in March. And then when we started having COVID, which is the orange graph, it was a totally separate outbreak. So one of the main worries that we have this year, both in Europe, Asia, and in the United States, is that in the Northern Hemisphere, we're going to have an outbreak of COVID, a second wave, at the same time as we have a simultaneous flu outbreak, which we did not have last year, and our medical resources were stretched to the limit. Next slide. We may have the second wave and the flu at the same time, and we may have a co-epidemic occur, and that's a big worry for most of us. Next. Now I want to talk to you a little bit about the metrics we look at when we try to follow this outbreak. There's a metric called the R0 or R0. It's calculated by a complex algorithm and measures how many persons will get a disease from each patient who is actively infected. The estimated R0 for COVID is about 2.5. Now the RT, or the transmission rate of the disease, is a little bit different. It measures a disease spread over a specific period of time, and we use it to measure the effects of control measures. So say you lock down the population, don't let them leave their houses. You can follow the RT on a daily or weekly basis to see if that control measure is working. If the RT is greater than 1, the disease is increasing. If it's at 1, the disease is plateau. And if it's less than 1, you're getting control of the viral process. It's lessening, and it could eventually disappear. Next. I just want to throw out an example of some of the contagious virus infections. Measles is probably the most contagious infection that we know of. It has an R0 of 18. You can see that on the far right of the slide, as opposed to hepatitis C, which is 2. And I did mention that COVID-19 is estimated to be between 2 and 3. So measles is very highly contagious, and for every person infected, they will infect 18 others if they're not immune by vaccination or prior infection. Next. So what does that really mean? Okay, well, let's look at the number of cases. This was in New Jersey. On March 15th, we were clearly more than 1. We were 5.3. Then, as you can see, it dropped down to 0.8, 0.7, 0.9, and now it's 1.24. And I put on the bottom of the slide, right now on October 3rd, when I made this slide, the reproduction rate in Bulgaria was 1.13. So if you're sitting there looking at me now and saying, well, we haven't had many cases in Bulgaria, well, actually, your reproduction rate is now more than 1. So you're not on an epidemic curve but right now, but you're certainly on the increasing number of cases curve. So you have to be watchful that, you know, this disease can spread exponentially. So you really may be looking at a second wave coming very shortly. Next. So what metric to follow? I mean, we look at this every day and try to say, you know, what should we really be looking at to say whether we should be universally testing all our admissions to the hospital? How are we doing in controlling the epidemic? Should more public policy be put into place to control it? There are several things you can look at, and there's really a problem with all of them. If you look at the number of cases is really dependent on how much testing you do. If you have a very efficient testing, operation like in South Korea, you could have a lot of cases because you're testing a lot and you're going to be picking up asymptomatics. And if you're doing a lot of testing, the percent positive is going to be low because you're going to be picking up asymptomatics or mildly symptomatic patients who are not going to be presenting to the hospital. The number hospitalized is actually probably a pretty good metric to follow, or as I mentioned before, the ICU admissions. And actually Belgium announced last week that this is the metric they're going to be following from now on, the number hospitalized, because it really does tell you who the really sick patients are who may die and what resources are being used in your healthcare system. The number of deaths is useful also, but again, this can be manipulated. There was some concern early on, and some countries were charged that they were saying their death rate was low, but they were attributing deaths in people who had COPD or congestive heart failure. Even if they had COVID, if the primary cause of death they felt was congestive heart failure, they were putting that down as the cause of death. In the United States now, anybody who has COVID, even if they have comorbidities, we define them as a COVID death. So that's going to affect the number of deaths. It's also going to affect the death rate. And the reproduction rate, I think, is a good thing to follow besides the number hospitalized. And I did mention a little bit about that already. Next slide. The incubation period of the disease is 2 to 14 days. It's usually about 5 days. So that's the incubation period, as you know, is a time from when you first contacted somebody who had the disease to when you come down with the disease. The first phase, it really is a very odd disease. The first phase is like flu-like symptoms, and it really corresponds to viral replication. And the second phase is what we call the cytokine storm, which is really an overreaction of the immune system, which leads to respiratory failure. And MSOF is short for multi-system organ failure, where kidneys, lungs, heart, everything fails. And that usually occurs between 7 and 14 days. So people, get a false sense of security the first week where they just have mild symptoms, cold symptoms, little cough, a little bit of fever. But then they can get very sick very rapidly between 7 and 14 days and present in respiratory failure to the emergency department. Next. Now, I'm going to be quoting the MMWR many times. This is the Morbidity and Mortality Weekly Report. It's the newsletter of the Centers for Disease Control in the United States. It comes out weekly. And I think it's a pretty good indicator of what's going on in the rest of the world also. But on June 15th, they reviewed the first 600,000 cases in the United States. And early on, the case definition of COVID was fever, cough, and shortness of breath. I have them highlighted in yellow. But subsequently to that, you can see that a lot of other symptoms have been added: muscle aches, headaches, sore throat, diarrhea, and sort of uniquely, a loss of smell and taste. Sometimes people only have this as their symptom with nothing else. I wanted to highlight a couple things. At many of the airports, they started doing a check for fevers. Well, even in symptomatic patients, fever is only present less than half the time. So if you screen everybody for fever, you're still going to be missing a lot of even symptomatic people. And as I mentioned, a good portion of patients are even asymptomatic. So it's not a very effective tool. And in fact, in the United States, we stopped screening at airports now because we didn't find it very effective. Next. I think another thing we're learning about this disease is that symptoms are really prolonged, and they have a term for this. They call people who have some period of time long haulers. Typically when we think of a virus, we think about a 1 or 2 week illness, but many patients with COVID are on ventilators for weeks. And those who recover often have persistent shortness of breath and profound fatigue for a long time. The Centers for Disease Control in the United States did a phone survey, and they looked at outpatients, and only 2/3 of outpatients had returned to baseline at 2 to 3 weeks, and only about 40% of people who had been admitted to the hospital. So this is a prolonged disease. What we don't know is whether there'll be permanent lung damage in sick patients who survive. Neurological symptoms such as confusion, hallucinations are common and can be protracted. And people on ventilators for a long time, we don't know whether their symptoms when they come off and they can barely walk or breathe, whether that's due to post-ICU syndrome, which is very well defined with acute respiratory distress syndrome, where people who are on ventilators for 4, 5, 6 weeks often have neurological symptoms and are very weak and they can't even hardly move. Is this just a post-ICU syndrome, or is it a true effect of the virus? And we're even worried about young people because there's a recent study showing that MRIs of the heart done on athletes, they looked at 100 athletes who were only mildly affected by COVID, and they looked at their MRIs of their hearts, and they found that 60% had abnormalities consistent with cardiomyopathy. The question is, there's a lot of viruses, even flu or mononucleosis can have cardiomyopathy associated with it. So is this permanent, or was this just a very sensitive pickup on an MRI? We really don't know yet. Now the age distribution, as I said, this has really changed. This was the first 600,000 cases. You can see it almost didn't affect young people at all early on. It was all the older population over 50. But now the population that was 20 to 40 was 10% before, but now it's over 50%. But as I said, 10 days later, their parents are going to be affected, and then 2 to 3 weeks later, their grandparents will be affected. So you can assume that if you're seeing a lot of cases in a lung population, this will translate into spread to older, more high-risk patients later on. Next. We look at this outbreak and we say, well, only the old people are dying. It doesn't matter if I'm 30 and I go to a bar. Well, that's true. If you get it as when you're 30 years old, you're not going to be nearly as affected. But COVID isn't disproportionately affecting old people. I looked at some data from influenza, and 83% of deaths from influenza in 2018 were over 65, and 80% of the deaths from COVID are over 65. What's really unique about this disease, and I'm going to discuss this in greater detail, is that usually there's not a sex prevalence of this disease, but in COVID, males are much more likely to get the disease and much more likely to die than females. If you're over 80, the risk of dying is 20 times if you're 50 and 100 times if you're 40. So clearly, being older is one of the highest risk factors for dying of this disease. And I also looked at deaths in the United States, and as you might imagine, that if you're older, you just die. In 2018, I looked at the deaths in the United States, and I excluded accidents, homicides, and drug overdose. And 80% of the deaths basically are over 65. So old people tend to die of almost all diseases. One thing I wanted to highlight, though, was the COVID death rate. We think that because we have fancy ICU now, is that we're really doing well with COVID, but we're really not doing that well. The death rate, if you're on a ventilator in the ICU, in our hospitals and throughout the world, is 50 to 60%. It's not 20%, it's not 10%, it's really over half. So it's a very serious disease if you end up on a ventilator. Next slide. Now the severity, I looked at the Chinese CDC, or Centers for Disease Control, looked at their first 45,000 cases, and about 81% had mild symptoms, just common cold symptoms. Severe symptoms as defined by shortness of breath or a low O2 saturation was about 15%. In critical disease, respiratory failure, septic shock, multi-organ failure was about 5%. The mortality in Hubei province, where Wuhan is, where their center of their outbreak was about 3%. But early on, they were like we were in New Jersey, where their demand for care really overwhelmed their health resources, and they couldn't cope with it. So their mortality was quite high, 3%. But if you look at the rest of China, their mortality was much lower, 0.4%, where they didn't have quite the influx of new patients. Next. Comorbidities are a big factor here. I did mention age as a risk factor for dying, but Cardiovascular disease is very high, about a third, diabetes, lung disease, kidney disease. And your risk of hospitalization is 6 times higher, and deaths are 12 times higher if you have one of these comorbidities listed above. The annual flu is about a 0.1% mortality. Now, the reason we have so many deaths from flu is that each year in the world we have hundreds of thousands, hundreds of millions of cases. So 0.1% of 100 million is going to be 100,000 deaths. So that's why flu has a high mortality, even though, you know, in terms of cases, just because there's a lot of people who get the flu. So other things to consider besides comorbidities, race has also been considered, and obesity. Blood type O seems to be somewhat protective, although this isn't perfectly clear. If you're blood type O, you have a 10 to 15% chance, less chance of having serious disease. Next. Now, you know, in the United States, we have a compilation of people from all over the world who have settled in the United States, and Hispanics, particularly from Central and South America, and African Americans make up a good portion of our population. And they're 3 times as likely to get infected and 2 times as likely to die as other races. So the question is it race, or is it other factors, or is it genetics that are causing them to be sicker more? In the US, the percent of cases in our Hispanic population is 1/3, blacks are 20%, but the percent of the population is only 18 and 13%. And the American Indian, which is our indigenous population, is about 1% of the population, but half of that, but that's the percentage of people with COVID, but they're disproportionately affected by COVID compared to their percentage of the population. So now, what's the effect of race? Is it increased comorbidities? We do know that Hispanics and blacks have higher incidence of diabetes, hypertension, and obesity. The other thing I think, which is the most significant thing, is that African Americans and Hispanics tend to be at jobs where they can't work from home. They work in meatpacking plants, and they work in factories, and they're bus drivers, and they're essential workers. And only 13% of Hispanics have jobs where they can work at home. And a recent study showed that about 30% of whites have been, or Caucasians in the United States, are working from home. So if you work from home, obviously you're at less risk of getting contact with people who might have COVID. So there's greater exposure in our minority populations in the workplace. And then I guess you could say lack of access to healthcare. You know, minorities have higher morbidity and mortality for most health conditions in the US at least. But you know what's very interesting about this is the statistic that I found is Hispanics actually have increased longevity compared to the Caucasian population in the United States. And people don't really know why. They have less access to healthcare, but it's probably because they have multi-generational families, and older people have been shown where they are in a society where they're important and where they're seen as the matriarchs and patriarchs and the decision makers, that they tend to feel more useful, and that translates into longevity. And that's been shown all over the world, where elder populations which are staying active into older years tend to live longer. Next. So I brought up the gender effect before, that males were 60% of the death rate, and females were 40%. It's not so much with flu, but most infectious diseases are more deadly in males than females. And I looked up possible reasons. No one really knows. Looking at genetic reasons, estrogens, which the female population have, enhance the immune system. The X chromosome has 60 genes associated with immunity, which of course men only have 1 X chromosome and females have 2. I think there are certainly cultural factors. The smoking rate in China for men is 54%, in women it's 3%. So smoking, COPD are risk factors for COVID, and they would lead to a higher death rate in men who smoke than women. And I think all over the world, men don't seek medical attention as often as women, and women keep their comorbidities under better control. But the enhanced immune system found in women sometimes is not always a good thing, since autoimmune disorders due to overactive immune system are 3 times as common in women as in men. Effect of COVID on pregnancy. You know, we recently had our own little pandemic in the world of virus that did births, as you can remember, just a short time ago. But while influenza in pregnancy leads to a 7-fold increase in hospitalization and pneumonia in pregnant women, COVID does not seem to confer a major increased risk in pregnant women, such as Zika virus did, which we had a few years ago. Hospitalization rate is higher, but not the mortality. And the hospitalization rate is higher just because if a woman gets COVID, we're just more worried, and we tend to admit women to the hospital who are pregnant more often just because we're worried. Small studies seem to show no major adverse effects on fetuses with infection in their mothers. Next. Now, I'm not going to spend a lot of time on treatment options just because they don't really work very well. There's been a lot of drugs that have been bandied as being cures, but they're not really. And even the drugs that have been shown to be effective are just really marginally effective. I've highlighted 2 that were shown in the recovery trial in the UK to show some benefit. Remdesivir seemed to decrease symptoms by 4 days, but didn't really have an effect on mortality. And steroids, dexamethasone, was shown to decrease mortality in people who were ventilated by about 1/3. So now the standard of care in most of the world is give remdesivir and steroids. Remdesivir in the first part, the first week of the disease where there's viral replication, and then steroids where you're in the second part of the disease where you're in the inflammatory phase or the cytokine storm. Now, all the other things, vitamin D, statin, zinc, Pepsid, colchicine, all of these things, people have shown in small studies that maybe they're helpful, but I don't think, you can try them because there's certainly, there's no or very little risk to them, but I don't think I can say with certainty that they really do help. Next. Next slide. I think that I can say about almost all diseases that whenever we don't have a good treatment, there's always a proliferation of options. If you have a good treatment that really works, then there's only one treatment. And none of the treatments I mentioned are really game changers. That's sort of a term we use in the United States when we talk about a drug that really works well. I think the eventual treatment will probably be similar to HIV, where AZT or zidovudine was an incremental benefit when it first came out in the late 80s. But only when it was combined in a treatment cocktail did real success become a possibility in treating AIDS. And now they're trying to do studies combining several antivirals with anti-inflammatory drugs and see if that really gives added benefit, but those are still in their infancy, those studies. It seems like the only treatment options that truly work are proning to improve oxygenation. And we even did a study at our own hospital, Atlantic Health, where we showed that proning helped about 5% of the time with O2 saturation in the emergency room. And proning is where you put people who are short of breath, instead of having them lay on their backs, you have them lay on their stomach, which improves aeration to the posterior aspect of their lungs. In anticoagulation, we really found that this disease seems to lead to coagulation problems, leading to both to venous coagulation and arterial. So young people are presenting with strokes, they're getting deep vein thrombosis, etc. And although it's unclear exactly what you should do, where most places are giving at least prophylactic anticoagulation to our very sick patients in the ICU to decrease the incidence of clotting. Next slide. So what is the mortality? My estimates is about 0.5 to 1%. This is based on more testing early on of the sickest patients, such as in South Korea. And also there was that boat, the cruise ship in Tokyo Harbor, the Diamond Princess, where there were elderly population, but you would presume if you're on a cruise, you were a healthy elderly. And it was about 0.5 to 1%. Other diseases, influenza, I already mentioned, was about 0.1% mortality. And the Spanish flu was 2%. And other coronaviruses, but that didn't tend to be as prevalent as COVID. SARS was 10%, and the Middle Eastern Respiratory Syndrome was 35%. Next. Transmission, this is really the key question here. It obviously is a very highly contagious disease. There's a big debate going on whether this is droplet or airborne. In the last week, the US CDC said that probably it can be spread by airborne route. Now, the difference between droplet and airborne is droplet is large droplets fall within 6 weeks of origination. The prototype of that disease is flu. So if you stand 6 feet from a person who's sick, you should get infected. Airborne is a little bit different. The airborne diseases are a lot more contagious because small droplets stay suspended in the air, can be carried more than 6 feet, stay suspended for prolonged intervals. Like if you have measles and you leave a room, the measles virus can stay suspended in small particles in the air for 2 or 3 hours after you leave the room. So that makes it much more contagious. So the debate is still up in the air about it. It appears that this disease is spread mostly by droplets, but certainly if you do an aerosolizing procedure, like doing bronchoscopy or you intubate someone, that's going to increase the risk. And there might be some instances where people are singing in choirs or something like that, where they are aerosolizing and spreading it further than 6 feet from where they are. We really don't know what the risk of fomites are. You probably found in Europe, just like in the United States, everyone went to the supermarkets and bought out all of the disinfectants. But we don't really know what contaminated surfaces, whether they spread disease. We do know that on doorknobs and on cardboard and things like that, the virus can persist for 2 or 3 days, but it's unclear whether that's an efficient way of transmitting disease. Because remember, it has to go from the inanimate object up to your nose or mouth, and you don't know how many viral particles can really exist and how quickly they die from an inanimate object. I think the major thing and the reason why we're having such an explosive spread of this virus is that there are 20 to 50% of all cases are probably in asymptomatic patients. Next. In Munich, they studied 9 patients, and they showed that even though patients are still positive often on testing for over a week, pharyngeal shedding was high for the first week of illness and then rapidly dropped off, and that really you couldn't culture the virus more than 8 to 10 days after the illness began. So next slide. Currently in the United States, we recommend that if you have mild symptoms, 10 days you should be isolated from the time you have the initial symptom. And for people who are severely or critically ill, we're using a longer period of time, 20 days from onset of symptoms, as a time to go back to normal life without isolation. I think we've already answered this question. Early on, we thought that the coronavirus was a cold virus, which are predominantly in the winter, so that warm weather would cause it to fall in the summer. But that never happened when Africa, Singapore, the Brazilian Amazon had major outbreaks this last summer. Next. This is a big question in everybody's mind. Should we fly airplanes? Should you go home and visit your mom in the UK if you're in Bulgaria now? Well, they just looked at this actually in the last week, and although they don't have really good control study, airplanes, particularly those built after 1990, have these high efficiency particulate air filters or HEPA filters that airplanes mix clean air from the outside with these HEPA filter circulation. So really air enters from overhead and flows downward through the floor vents, usually pretty much at the same seat or just the next row. And it probably is lower risk than classrooms, supermarkets, or trains. And there's been only 42 known cases of aircraft-related transmission so far. But this has not been studied that well. And certainly, if the middle seat is occupied and you're on the aisle, I don't think that you're not going to be at low risk of getting disease from somebody who might have it next to you. I think there's a lot of unintended consequences. Every time you have something occur, even if you try to control it, you have unintended consequences. And there's a lot with this virus. Schools are closing, parents at home and can't work. There's increased domestic violence and alcoholism and drug abuse. more food insecurity, and poor students are falling further behind because they require in-house learning. The public avoids coming to the hospital for other illnesses, and death rates at home soar for most medical problems. Actually, the CDC looked at this in June, and they found that emergency department visits were down 42% compared to 2019. 23% even for serious diseases such as MI, and 20% for strokes. You would think that if you had chest pain, crushing chest pain, you would go to a hospital, but COVID was keeping people away from hospitals. They were afraid to go. The other big effect is immunization. Rates are down as much as 60% in some areas, raising the specter of measles, pertussis, etc. in the very near future. Next. Should we open this over the world? Yes, because poor children falling further behind. Many children have food insecurity and may get nutritious meals in school. E-learning is certainly not a substitute for in-class learning for young children. Parents are having trouble returning to work because they need someone to care for their children. So it's a real problem. This people that feel no is there was a study from Wuhan in Science that found that children were 1/3 as susceptible as adults, but had 3 times as many contacts. If schools are reopened, the reproduction rate possibly will increase. And a study from Germany showed that children, even asymptomatic ones, have just as much virus as symptomatic adults, and therefore may be as likely to spread disease. Next. I think we can learn from other countries here. There's a lot of experiments going on all over Europe right now. The most famous one is the Swedish experiment, where they pretty much said that we are not going to close down our economy. They believe that students face little risk from the virus and far more from missing months of school. So they kept their schools open. And there was very little exacerbated the outbreak. Initially, Sweden's no lockdown policy was shunned by its other Nordic neighbors, but eventually Denmark and Norway opened schools, and neither did show a resurgence of cases. But they did start at a very low rate of cases before they opened their schools. Most schools that have been successful have had students come back in pods of 12. They eat lunch together, taught by only one teacher in socially distant classrooms. Arrival times and even days attended are staggered. So I think we can learn from other countries about what to do in our own country based on this data. Next. So this is a little bit conjecture. How long will all these restrict? Probably indefinitely. There probably is no totally risk-free situations, and we'll likely be doing this, so at least some form of mitigation for many months or even a year or more. Quarantine certainly does work, but it's a very blunt instrument. And that once control of an outbreak is achieved, we need to come up with smart ways of getting the economy functioning without sacrificing life. And this is a difficult balancing act. My last part of my talk, I'm going to just sort of try to guess what's going to happen in the next few months. Do you think that we can stop this pandemic before a vaccine is available? Wow. Everybody thinks we can't stop it. Some people think we can. Well, there have been some countries that have done. Let's look at the data, okay? Most people feel that we can't do it. The mitigation techniques that have worked or tried to work, first of all, if we get a good vaccine, that may work. There's 130 vaccines now in some sort of controlled trial somewhere in the world. The US government is funding 5 of them. And we have this thing called warp speed, where we're actually producing the vaccine before we even know that whether it's effective, to see if we can get something going in the next few months. Next thing is herd immunity. We'll talk a little bit about that. Mask wearing, does it work? Lockdown, social distancing, does that work? Aggressive testing and contact tracing has been tried in many countries. Isolate those exposed. And then, of course, control superspreader events. Let's look at each of these and see if they work. When will we have a successful vaccine? Perhaps later this year. But just for I went back and looked at this, was mumps. It took 4 years between 1963 and 1967. Most vaccines take 10 to 20 years, and 1/3 to 1/2 of them fail in a late stage of testing. And the other problem is a lot of the vaccines are 2 doses. And if you 2-dose 8 billion people in the world, that may take 6 to 9 months to accomplish, even for high-risk groups, for example, the elderly or healthcare workers. And then, of course, is how effective will the vaccine be? They're not going to approve it in the United States, at least, unless it's at least 50% effective, which is approximately what flu is. But if we only are 50% effective, we're going to need a much higher level of the population vaccinated to achieve immunity. Next. Herd immunity. Well, you could almost argue that the Swedish experiment is herd immunity. They're saying that the people don't get sick very much from this. They have mild symptoms. And if we protect our elderly, then we'll have herd immunity eventually. Unfortunately, it didn't work out so well so far in Sweden that they did have a death rate, which was the highest in Europe per population. And they did have a high death rate in their nursing homes also. So even the person who designed this experiment says that they would probably change things if they had to do it again. But the definition of herd immunity actually came up with veterinarians in the early 20th century. They're interested in livestock, not people, and they coined this term, marking the population of animals that would have to be immune to a disease to prevent further cases. Now, in certain areas of the world, like in certain parts of Brooklyn neighborhoods where they were hard hit by COVID, 20% of Manhattan, for example, had antibody, but some neighborhoods in other parts of New York had 70% immunity, as demonstrated by antibody. But most of the world is about 10%, like you look at Madrid or London's at 15%. So we don't know how long the immunity is going to last, and 10 or 15% certainly is not enough for herd immunity. Now, the National Academy of Science just came out with a very, very dense document, 237 pages long, and I'll summarize it in this slide. But basically, it said if the R0 is low enough, that tells you what level of vaccination you need to get herd immunity. If the R0 is 4, meaning each ill person infects 4 others, the goal is to have only one of the 4 remain susceptible, so that basically you're only infected 1 or less people. And the vaccine then would need to protect 3 or 75% to stop the disease. And that's presuming that that vaccine is 100% effective. So, for example, let me go through this algorithm with you. If measles has an R0 of 18, you have to protect 17 of the people to protect you from having a measles outbreak. So that means you have to have a vaccination level for measles, which is very high at 94%. If COVID has an R0 of 2 to 3, as I mentioned, so you have to be about 2/3 of the population need to be immune either from prior disease or vaccination for this thing to eventually die down. Next. In July, Springfield and exposed 2 symptom caregivers for a total of days before they stopped work at testing. But the shop required masks, but no stipulation as to the type of mask. So about 1/2 of them were actually just cloth bandinos. They weren't actually surgical masks. 139 clients were followed clinically for 1 month. No one developed any clinical symptoms. Then they went back and they tested all those who agreed to testing, about 1/2 of them, and nasal swabs on all of them were negative. So the perfect argument would be, well, maybe these 2 people weren't spreaders because, some people spread disease and some don't. But one of the 2 workers actually spread it to the other person and spread it to 4 cohabitants of their household at home. So I don't think you could say that they weren't spreading the disease. So I think it's very reassuring that if you do wear a mask, particularly in indoor spaces, even if it's just a cloth mask, that you actually can protect yourself from this disease. Next. Social distances in lockdown does work, but there are terrible social consequences, especially in developing countries with little or no social networks. Marginalized day workers cannot support their families, and hunger is a bigger problem than COVID. I think a perfect example of this is India. where they went into a very tight lockdown. Premier Modi did initially, and it worked very well. But then migrant workers, which make up a big population of the cities of India, could not support themselves. They went back to the rural villages, spreading the virus even more. And then I've read stories about poor people who are actually hiding their illnesses in Mexico and Indonesia, et cetera, just because they don't want to isolate themselves, because then they can't work. And if they can't work, they can't support their family. And certainly this keeps spreading disease. More testing and contact tracing. There are many problems with this also. Testing is very expensive and short supply, and often results delayed 2 to 5 days when cases can be asymptomatic and spreading disease. And contact tracing has just not been successful in some countries. In my own country, the US, 20 to 50% of people just don't answer the phone of an unknown number because they think it's a spam call. And 50 to 60% don't cooperate with naming their contacts. It is a problem with all democracies, I guess, where people sometimes do not trust their governments or are unwilling to give up individual freedoms for the greater good. But I must say in my bottom slide there that some democracies, New Zealand, Australia, South Korea, and Taiwan, there's been a real sense of social responsibility prevailing, and contact tracing was very successful, getting 15 contacts per person in those countries versus 1 to 2 in the US. Next. The other thing is, the last thing is controlling super spreader events. We're finding that where the population is of new cases is quite low, 80% of new cases are really super spreader events. And I would define a super spreader events as prolonged contact with others without a mask in crowded indoor situations where the risk indoors is 18 times the risk outdoors. So the high risk thing is bars. As you may know, they had a little second wave in South Korea where a 28-year-old visited 6 bars on a Saturday night and affected 50 to 100 other people, and there was a whole bunch of other secondary cases. Crowded restaurants, weddings and large indoor parties, choirs and church services. There was an outbreak was described in one of our cities in the United States where there was a 2.5-hour choir practice, 61 people, half of them, the attack rate was 53%, developed COVID, and there were 20 secondary cases and family members, 3 hospitalized and 2 died. And of course, when you're in a choir practice, you don't have a mask on and you're projecting aerosols because you're speaking loudly or singing. So that's a good environment to spread it to other people. Next slide. I think eventually we may do what Boris Johnson said, the British Prime Minister. If the number of cases can be lowered to very low levels, perhaps less than 50 cases per city or region, then any flare can be dealt with very aggressively with ring testing around cases, aggressive contact tracing, and isolation of involved individuals. And actually, they're doing this concept pretty effectively now, the whack-a-mole concept. In Germany, South Korea, and other areas where cases have fallen to very low levels. Next. So I'm running a little bit late, but just give me a forbearance for a couple more minutes. This is my prediction. I think there's a couple of scenarios here. The optimistic scenarios are that the first wave dies down, we have a vaccine this coming fall, and there's no second wave. The second optimistic scenario is the number of cases fall to a very low level, so each small cluster can be thoroughly investigated, and we can do the whack-a-mole thing that I just described, where you do contact isolation and ring testing, etc. Next. Now, the pessimistic scenarios are we get no vaccine or good treatment. We have a second and perhaps a third wave, as we did in the Spanish flu in 1918, where we had 50 to 100 million people killed worldwide. A very smart infectious disease guy in the United States came out in June and said that, that he didn't think that the multi-wave 2018 flu epidemic would materialize, and we may just have an outbreak which continues to spread with no let-up over 18 to 24 months until there is herd immunity from infection or a vaccine or both. Next. I think that some countries have done a really good job. New Zealand, they went go hard, go early. Jacinda Ardern, who is the Prime Minister of New Zealand, designed this concept. She's a very smart lady who What they did is when they first cases in New Zealand, you may say that's not representative of complicated democracies like or China, but they only have 7 million people in New Zealand. But as soon as they had cases, they totally isolated the country. And when they recently had 4 new cases in Auckland, they shut down Auckland, the capital. And they had secondary cases, but they really went hard in, and now they're reopening and they're back to normal again. So if you go hard and go early, that works very well. Have adequate testing and contact tracing. South Korea certainly was an example of that. They were really revved up to do a lot of testing early on. They do extensive contact tracing, and they've been able to control their outbreaks. Sweden was part of it. They had a higher death rate than Finland, Denmark, and Norway. I mentioned what happened in India about the migrants spreading a disease. They couldn't stay locked down forever, and it worked initially, but they couldn't keep on. Next. The Southeast Asian experience is interesting. It's quite large, 70 million. It's not in New Zealand. They've only had 3,200 cases, 8 deaths, in 7 weeks. There's no deaths in Vietnam, and there's been no transmission in 3 months. And Vietnam is 100 million people. What's going on here? Well, first of all, if you go to Southeast Asia, you know that everyone wears a mask practically, even when they're not sick. So it's very common to wear masks in that area, so that may help. They have a very low rate of pre-existing conditions. Like in Southeast Asia, the obesity rate is 4 to 6% versus 42% in the United States. They may not be testing, as happens in a lot of countries, and there may be genetic factors. One thing I wanted to mention, a lot of people say, like in the UK, France, or the United States, is that, we're democracies. We can't love people. But, Australia and New Zealand are pretty effective democracies, and they really have very tough rules that have been accepted by their people. Let me give you 2 examples. I gave you New Zealand already, which requires hotel isolation for 2 weeks for all arriving travelers. And they found a traveler leaving the hotel to go to a local bar, and they arrested him and fined him. In Australia, they had an interesting story. They had a little outbreak recently in in New South Wales. And they heard this story that I thought was interesting. One of the fast food chains called KFC, which is Kentucky Fried Chicken, got an order for 20 people for takeout. And they had a restriction on no gatherings more than 10 people. The store called the authorities. The police went to the party. They found 20 people there, and they fined them the equivalent of about 25,000 euros for violating the quarantine. So very stiff penalties. And the other thing about choosing between saving lives and the economy, the Swedish economy suffered quite severely, even though they opened up, just because we really are a global economy now. So supply chains are global. They shut down car factories in Europe. That affects car factories in Sweden. So, it's going to affect everybody if other areas are shut down. And then the other thing they found in Sweden is that high-risk citizens, for example, the elderly, stopped going out because they were afraid of getting infected because they knew that their disease wasn't that well controlled in their country. So opening the economy early does not avoid the economic disruption. It may make things worse and delay recovery. Next. So my prediction is that governments will avoid the total lockdowns that were undertaken early on. They're finding demonstrations now in Paris and Berlin and in the United States when people are trying to, with locking down, and people are just getting pandemic fatigue. So I think there'll be more emphasis on protecting vulnerable populations, for example, the elderly, and prohibiting other events indoors when we have cases spiking. And I think a combination of vaccine availability and more actual disease will eventually get us to herd immunity, probably late next year. But I've been wrong about this disease since the beginning, so you have to really take that with a grain of salt. We really just don't know where this is going to go in the coming months.